And now we'll hear Dr. Robert Bransfield. And Robert is a pioneer in the domain of Lyme advocacy, and he's a huge experience as a neurologist and a psychiatrist. And I always admire his huge clinical experience about the management of all these diseases. So thank you, Bob.
Thank you, and thank you for inviting me here. Now, in 2010, we had our first European ILADS meeting. And before the meeting, I traveled through Ireland trying to organize Lyme disease awareness. And it was very challenging to talk with a couple of support group people. And it's good to see that you finally improved awareness here to have a meeting like this. It was a great advance. So let me just, okay. All right, now, what's the history of mental illness? So it used to be demon possession and torture was a treatment. Then we blamed it on your mother. Then we blamed it on serotonin. Then we blamed it on genes. And now we're looking at chronic infections and immune reaction. But if you adhere to that, then you're guilty of heresy, and then you're possessed by a demon and you need punishment. So we went full circle, okay? So microbes and mental illness. So a number of infectious agents contribute to neuropsychiatric illness. And I think a good way to look at this is the phrase complex interactive infections. It's usually not one single organism, but an interaction. We could call them stealth, crypto, many different names, and many of these are vector-borne, but not all of them. Now, when we have injury to when it causes psychiatric symptoms, you have to think that the brain is a regulatory mechanism, somewhat like the gear shift of a car, and you should be in the right gear for the right environmental circumstance. And when you have trauma to the brain, it disrupts these regulatory mechanisms. So you're too afraid when you don't need to be, or you're not afraid enough when you're shifted. So we can think of damage to the cortex, the limbic system, and all the different parts of the nervous system. And you can have patients that have multiple impairments at the same time with all these different parts of the nervous system, and also different parts to the soma, to the body, so GI, cardiac, etc. So the right word is polymorbidity. It's not just comorbidity. So what are the usual suspects when we're dealing with these infections? And this is a part of a journal article that we've been working on for a long time. And we really went through thousands of journal articles condensing this, looking at the different infections that are associated with psychiatric illness. And so you have spirochetes, different spirochetes, you have other bacteria, and it's a lot of these are the same infections that keep coming up again and again, but some only come up occasionally. And then you have different viruses and parasites and fungal infections. And many of these are mixed infections, not just one or the other. Now, the next thing we looked at is looking at different conditions. And we looked at 7 different conditions and looked at what's the medical literature connecting in various infections with these conditions. So the first thing we looked at was autism. And there's a number of different infections associated with autism. Now, some of these are hit and run infection where they do their injury and they're gone. Others are chronic, persistent infection. And we also have congenital infection. And then we have sometimes children that develop normally, and then they have regressive autism, like around the age of 1.5 or 2. And that's a different thing. So these were the infections associated with it. Another thing we found is looking at the gut. And when you think of the microbiome, some people just think of the gut. It's a lot more than the gut. You have microbes in other parts of the body, but the gut is a part of it too. And you often see the shift of less of the good bacteria, more of the bad bacteria. And the shift that I'm describing here, we also see with Parkinson's disease. So these are some of the usual suspects with autism. Now, pressing the wrong thing here. Okay. All right. Now, these are 14 journal articles on autism and Lyme. I think about 20% of autism is associated with Lyme or tick-borne disease. And I want to draw your attention to the one at the top. And in that article, we did treatment with significant improvement with autism associated with Lyme disease. Now, what we found is that 92% of autistic children with Lyme disease had reactivity to the 31 and 34 band. So the removal of those with the commonly done Western blot testing has contributed probably to an increase, because now we're going to miss those cases. We also saw a higher prevalence of autism in states that had a high prevalence in Lyme and a lower prevalence in states that had a lower prevalence. Now, schizophrenia. Schizophrenia, we saw this group of infections, and it's autism, schizophrenia, and bipolar. A lot isn't just the infection, but the timing of it. And I think a lot of these infections, when it's early in childhood or pregnancy, you're more likely to have an effect. But you're starting to see some of the same usual suspects that keep reappearing with Bartonella, Borrelia, and different viruses and toxoplasmosis. So that's schizophrenia, and then this is bipolar, Babesia, Bartonella, Borrelia, different viruses, toxoplasmosis again. And again, it's the timing. Invariably, if you get these in either pregnancy, early childhood, midlife or late life, it has a very different effect. Depression, some of the same infections. We're seeing SARS-CoV-2 also that keeps popping up now with these conditions. Something like West Nile virus, we just see that with depression. You don't see some of these infections we see with multiple different psychiatric illnesses, whereas some you may just see with one or two psychiatric illnesses. And anxiety disorders, and then particularly with strep, with OCD, and again, the tick-borne disease appear. Suicidality, we looked at that, and this is something I've studied quite a bit, and again, with Lyme, with tick-borne diseases. Then also aggressiveness we looked at, and that's quite significant. We looked at also aggressiveness in animals, with animal models, and similar thing where you can see the gut changes as one of the models in looking at that, but that's not the only model. And a lot of the same usual suspects. Now, in looking at violence, if you think of that, and it's hard for, since I have a captive audience, I have to go off on this because this is a big thing to me. It's a great concern that, but when I did a study, only 1% of the Lyme patients I saw were homicidal. That's a small percent of Lyme patients, but it's a big percent, a big number of people in the world. So when you look at the world, violence isn't equally distributed. I was watching on the news today about massacre in a school in Africa, and there's certain hot zones, conflict zones, where there's constantly violence. This is one study that looked at the greater the infection load in a country, the lower the IQ. The lower the IQ and greater the neurological impairment, the greater the risk of violence. So violence, state of peace, isn't equally distributed throughout the world. And some parts of the world throughout history repeatedly have more violence than other parts of the world. And that also correlates with murder rate. You have higher murder rates in some parts of the world. So is there an infectious component? Afghanistan is a good example where that's been a war zone for a long time. And these are the vector-borne diseases in Afghanistan. So there's a very large number of them. And maybe we could stabilize these countries more by bringing in public health teams instead of military capability. But it isn't just vector-borne disease, there's other diseases too. So there may be this cycle of disease, mental impairment that contribute to violence that goes on forever. Now, this is a study in Iraq, and what they did is actually a very good study, and they looked at psychiatric patients, and they found that 66% of them had immune reactivity to Lyme disease, to Borrelia burgdorferi, either IgM or IgG or both. And then they did gene testing that supported this as well. So that's a very high number to correlate that with. There was also a study done in the Czech Republic a number of years ago. Also, a part of Russia, areas of Russia, there's a lot of tick-borne encephalitis and different tick-borne diseases, a very high prevalence there, and that maybe contribute to that being also a conflict zone. Now, I had a theory, this is my hypothesis, that in World War I, we had this huge number of infections. So it was before there was penicillin. And a lot of people came out of World War I brain injured. And many of those people then that were brain injured in World War I then became leaders and contributed to World War II. Now, what do these people have in common? Well, they're historically bad guys, or in one case, bad woman. And by historical records, they're either some degree of proof or speculation they all had syphilis, and that may have contributed to their behavior. Now, this is historical, but now we have more advanced weapon technology, and weapon technology is more advanced than mental health technology. So what happened if those individuals I just showed you had the weapons that we had today? What would have occurred, and what might that say for the future? So when we have these emerging diseases, how well do we approach this? Now, Dr. Green spoke on that before, but it seems like we do kind of a lousy job with this. So who gives us the best clinical advice when there's an emerging disease? And we have choices. One choice are our leaders and what we may call our backline bureaucrats and bureaucracy, okay? So that's who one group we can turn to for advice. Another group that we can turn to for advice are the doctors responsible for the long-term care of patients, not people in academic towers, but the people that go in a clinic year after year and have the long-term care for these people. So if you had a question, would you turn to the frontline doctors or the backline bureaucrats? But then the other question is, who has the control in healthcare? These people or these people? So how do we figure things out when there's an emerging disease? So we could look at frontline clinical observation. We could learn from our patients, or we could do double-blind controlled trials. But we really need to mesh the two together because it's a combination of both. So Sir William Osler was the father of American medicine, who wasn't American, who was Canadian. Said there's no more difficult art to acquire than art of observation. If you listen long enough, the patient will give you the diagnosis. And Yogi Berra said a similar thing. You can observe a lot by watching, or what I've never seen. I would have never seen it if I didn't believe it, which I think is a big thing that holds true for Lyme disease, where some people have a belief system where they close their mind to it. So when we have emerging diseases, we have to think outside the box. This is what we see whenever there's any new concept. There's the early innovators and the late laggards, and some people, there's a saying that science advances one funeral at a time, because people get entrenched with money, power, ego, and that can prevent the fostering of new ideas. So what do we do with patients? How are patients labeled who don't fit into the current dogma? And I did an article on this where we looked at psychosomatic, somatopsychic, multisystem illness, and medical uncertainty with Dr. Kaufman, or Dr. Friedman. And these were some of the diagnostic categories that that are thrown around. All in your head, medically unexplained symptoms, bodily distress disorder, psychogenic seizures, functional disorders, Munchausen's hypoxic conversion disorder. Now, a lot of these categories are really a way of saying, I don't know what it is, and I'm too lazy to try to figure it out. So I'll just say the patient's, it's all in their head and they're making it up. But that's not really the way it works. So this is a model of how these multi-system things occur. So a lot of times we have a disease that affects the entire body. It's like a shotgun blast, but everybody's injured differently with the shotgun blast. You can have somatic symptoms and you can have psychiatric symptoms from that injury. And somatic symptoms can cause mental distress. Psychiatric illness can cause physical distress. And there's always that medical uncertainty. And what you don't have is multi-system illness is never psychosomatic. It is never psychogenic. particularly when it occurs in late disease. So it is really easy to sort this out, but there's a gap between medicine and psychiatry. And a lot of people mislabel these complicated patients wrong. And that's partly why I end up seeing so many of these patients. Partly is I can't figure it out, so go find each a psychiatrist. Now, let's look at the pathophysiology. We have to think of like Einstein, time and space. So over time, there's these predisposing, precipitating factors, and then there can be infection or some other disease trigger. Then you get the immune reaction, a pathophysiological cascade, like a group of dominoes, leading to dysfunction, leading to symptoms, syndromes. And then when there's ineffective treatment, there's disease progression. We have to look at not only we have to use a multi-system approach where we're looking at all the contributors and the deterrents to disease, and it's the balance of the two. So we need this complicated formula. It's not simple. And this was something you saw yesterday, Paul Ewald's triangle. So we have this genetic susceptibilities, and there really aren't really mental illness genes. People look for it, but there's mental illness susceptibility genes. And then we have triggers, and some of those are infectious and some are non-infectious that interact with these susceptibilities. Now, if we look at disease models, all the easy diseases to explain have already been figured out. You have a clear cause, a pathophysiology, and a well-defined symptom complex. But instead, what we're struggling with now are diseases where there's multiple contributors, multiple pathophysiological pathways, and multiple ways that they manifest. But how can you study something like this with a controlled trial? And I think Abby did a good project yesterday where she showed a good model for approaching something like this, where you can do a study with this and show improvement. You have to figure out a different way, because the average randomized controlled trial only looks at one or two variables. And look at the number of variables you're dealing with complex disease. You have to have a different model when you study it. So this is actually from the CDC and NIH, where they recognize that many chronic diseases have an infectious basis, and they look at the Human Microbiome Project to help foster research in that area. So what are the infections, the physiology? Now, when you have an infection, part is what the parasite does to the host, and then the host reaction. It's a combination of two. So we have the parasite factors with disease, the host response. So some of that's like friendly fire in a war zone. When we look at different disease models, different diseases have a different cytokine profile. They each have a somewhat different cytokine profile. But one thing in common is all of them show an increase in interleukin-6. And also different infections have a different cytokine profile. And when you see, let's say, disease go from normal to illness and then recovery, you can see different genes upregulate and downregulate. Most of those genes that upregulate and downregulate are immune system genes rather than neurotransmitter genes. They're both, but they're two parallel networks of communication within the brain, the immune system and the neurotransmitter system. So vector-borne diseases, often you can see these tick-borne infections. They have multiple symptoms. Now, I find there are currently 493 references looking at Lyme or other tick-borne disease causing psychiatric illness. When IDS and 86 showing an association with dementia. When the IDSA had their guidelines, they looked at 4 studies and interpreted those 4 studies wrong. They cherry-picked and they ignored the other articles that existed. Now, when we see these symptoms, we have the tick-borne infection. We then have these immune effects. So you have some direct effects from the infection, but then some immune-mediated effects causing the symptoms. So this can result in many different clinical presentations. Part is the genetic vulnerability that some people have. Then we also see these other co-infections, multiple infections. So some are tick-borne co-infections, some are opportunistic infections. And I think Dr. Lambert's right. We see all these Lyme patients get these activation of these viruses, but there is no study about it. But when you look at someone and they get these infections, their viral titers go up, and then when they're treated, the viral titers drop. But I've never seen a journal article on it. So it's very similar to what you see with HIV or what you see with COVID, a similar thing where there's some immunosuppressant effect. So then that activation leads to disease progression and an increasing number and an increasing severity of symptoms that progress over time. So if we look at the prevalence of Lyme disease, this was a Chinese study where they looked at a meta-analysis, and basically 14.5% of the world was positive for Lyme disease. So going back to that number, when I found like only 1% of my patients were homicidal, when you look at 14.5% of the world being positive, then it's a rather scary number. So these are some of our tick-borne disease infections we're aware of, although the most significant thing is the last thing on it. Who knows what else, okay? When, when I started doing this years ago, I was just looking, we were looking at maybe Lyme, and then we kept thinking there's one more co-infection. And, where's it going to be 5-10 years from now when we have better technology to pick up a lot more of these co-infections that are part of this? So when we have this co-infection mix, there's different ways they interact where they facilitate the propagation of the disease process. So a good way to compare to is a fox hunt. If you wander through the woods with a rifle, you may not be very successful. But if you have people, horses, and dogs, it has a very different effect than one species alone. So when you have an interactive infection, 1 + 1 = 11, it doesn't equal 2, because of the multiplying effect with these additive infections, like particularly Borrelia, Babesia, Bartonella, which comes up a lot. So when we have these infections, we can think of 3 basic ways that they affect the brain. One is the meningovascular form, where it's vascular in nature. I think that especially happens with Bartonella, but it can happen with any of these, some of these infections. Who knows how much that's a part of it. Then the atrophic form, where it's inside the brain itself, and that's what some people may call neurolyme. And then there's, I think the more common thing that we deal with the most is infection in the body causing immune activity. And this immune activity then causes brain symptoms because those immune transmitters then impact the brain. That, I think, is the most common, but you can have all 3 going on at once. This shows an example of the first time where we can see a spirochete, this from an autopsy inside a neuron. And I think autopsies are really the ultimate gold standards that we need to rely on. And I'm glad to see the study that was presented yesterday. We need to do more of those. So early symptoms are more the brain fog, fatigue, and then we may see autoimmune symptoms. So you're seeing a failure of adaptive immunity, and then you can see biochemical changes. One major thing can be quinolinic acid. So what occurs is when you're in a pro-inflammatory state, serotonin doesn't convert, or tryptophan doesn't convert to serotonin, melatonin like we want it to. It instead can become quinolinic acid, which is neurotoxic. And that contributes to people being suicidal, homicidal. And this is true with a lot of infections with chronic inflammation and psychiatric illness. So that's a biochemical mechanism that causes pathology, in addition to other immune mechanisms. So my average patient that I see when I did my study is 9 years post-infection. That's usually when they end up starting in my office, where they end up in a psychiatrist's office. So you don't see the bad psychiatric symptoms a week, a month after they're infected. Usually it takes a while. So you can see early executive functioning, low-grade psych symptoms, some vegetative symptoms, but then as time goes on and the disease progresses, you see more severe symptoms with time. So if you look at the psychoimmunology, these are 6 articles on it. I'm not going to go into all the details of it, but it all makes sense of how these infections cause an immune effect that in turn cause the symptoms. And there's a number of different pathways by which that pathophysiological process occurs. So, and what we see is there's no adaptive immunity. So you think of, let's say you get an infection, you then get early inflammation, then adaptive immunity, and it's over. But that doesn't happen with Lyme disease. There isn't adaptive immunity. Instead, you get persistent inflammation, autoimmunity, and immune suppression. Okay, so this was Dr. Embers from one of her articles. She spoke yesterday where you get immune suppression and immune evasion, which when you think of that, it's absurd to rely on an immune-based test for an organism that suppresses and evades the immune system. So this is the point about the lack of inflammation. So it's almost like you're trying to shift to adaptive immunity. The body is, and it never quite does it. So, and is suppressing inflammation really the thing to do? Maybe that's what happens with doxycycline, because it's having some effect, but it's not really eradicating the infection. So we see this persistent inflammation. Now, this is one way to think of this. Think of three basic areas about the disease process. You have the infection, you have the immune system, and then you have symptoms. Those three areas. So you have pathological microbiome activity in your body, then that provokes the immune system in a pathological way. It causes symptoms, which in turn causes the patient to be stressed with disease progression. And when they're stressed, they're more immunocompromised. So it's a vicious cycle, like a group of dominoes. And how do you break that cycle is the question with treatment. This is an article I did looking at post-traumatic stress disorder and immune encephalopathies. Now, I compared that to immune disorders. So ideally, your nervous system responds to danger. It's not foreign, it's more danger. So with the immune system, if you're exposed to something dangerous, you get the early inflammation, then you get adaptive immunity and you're fine. If there's danger, if somebody walks in the room here that's dangerous, we're afraid, we respond, we adapt, it's done. But instead with post-traumatic stress, you never properly adapt. You never are able to differentiate danger from safety, and then you're chronically stressed. With immune disorders, there's a failure to differentiate. So there's that persistent inflammation and autoimmunity. There's the lack of adaptive immunity. So when the organism is stressed by that persistent activation of our stress response and our immune response, or both at the same time, then that makes us compromised and exposed to illnesses of many sorts. So sleep disorders are a big part of this, and I want to talk about this. So we all jumped out of bed this morning at 7 o'clock saying, I want to attack the world and conquer infectious disease. Well, we had a lot of energy. And then we go, and then around 4 in the afternoon, we get a biorhythm slump. I'm glad I'm not the 4 p.m. speaker. And if you're in England, you get crumpets and tea. If you're in America, you get Starbucks. If you're in Italy, you get a siesta, okay? But if you're in med school, you just push through it. And so then you get that biorhythm slump, a second wind, and then you go into deep sleep in the beginning of the night, and REM sleep, your batteries are charged, you're ready to go. But with chronic illnesses, it's not like that. You're half asleep, half awake, 24 hours a day. There's the loss of the normal circadian rhythm, and that's a big part of the disease progression. So if we look at a sleep study, we sleep in these sleep cycles. The first 2 sleep cycles are delta sleep, which has a lot to do with recovery. And then we have REM sleep, which is the heavy line towards morning. That's psychological recovery, that we're ready to go. But with people with chronic illness, it's more the bottom. And this is a big thing if you're not getting the delta sleep. So if you fail to have that delta sleep, you can see that what's called the terrible triad, which is fatigue, cognitive impairments, emotional lability, pain sensitivity, and you have a failure of growth hormone that has to do with normalizing endocrine function and also adaptive immunity. So your immune system isn't working as well. So the restorative sleep, the failure of the restorative sleep is critical with disease progression. And this was a study with Lyme patients. 100% had sleep disorders. And when you restrict sleep, a person is more immunocompromised. Particularly when you improve delta sleep, they recover better. And it's associated with fatigue and increased suicidal risk. So what happens when you sleep is the interstitial space between the neurons in your brain expands. So it's like that's when the brain takes out the garbage and gets rid of it. And so it's regenerative to the nervous system as well. And when you have that failure of deep sleep, and it contributes to this vicious cycle of neurodegenerative disease. So one way to think of it, and this is really combining a large number of articles, hyperarousal that you can't shut off can lead to insomnia. Insomnia can lead to anxiety disorder, and that can lead to depression, and chronic inadequately treated depression can lead to Alzheimer's over a period of decades. So when I do a sleep assessment, think of 3 basic questions. Like if you ask someone, what about sleep? And I say, well, you can't fall asleep. You never leave it at that. I say, well, what is it? What with onset, think of onset, middle of the night, early morning, quality of sleep. Do you have trouble turning off your brain, difficulty calming your emotions, or being able to relax physically? And then you go from there. And it's usually more trouble turning off the brain. And then is it random thoughts? Is it intrusive thoughts? Is it worry? Because that's, or is it creative thoughts? What prevents you? And this has a lot to do with how you treat it. You intervene with what's interfering with sleep. Things that wake people up in the middle of the night often have a physiological base. Early morning awakening often goes more with depression, but you want to treat that. So don't overlook sleep. I think it's such a simple thing. And when you improve sleep, you basically improve immune functioning, and your body's immune system can do a better job of figuring out how to fight these infections than any of us can do. So this is a study from Lyme.org where they looked at what's the main symptoms that people complain about with Lyme disease. Number 1 is fatigue. And also the study out of Hopkins, fatigue was high up there too. And it's very similar to this multi-system disease that people have. So when I do an assessment, think of basic clinical diagnosis in medical school, 101. You do a thorough assessment, you do a review of system that's relevant to the patient, and that's how you do it. You don't just do a single test and say, well, the test ruled it out when it's a flawed test. You have to do a basic medical student workup. Lab testing has a role, but you can't rely on it excessively because there's great limitations to it. So this is a study that I did with, and Michael Cook did the statistics, he's here. And so I looked at 100 patients that were clearly CDC positive, and then I did an analysis of their symptoms, and then figured out a diagnostic system based on that. And out of that, then figuring out I have different questionnaires, and anybody's free. I looked at 283 different symptoms. So it's very much like what we were talking about with COVID, where there's 200 symptoms, and some of these symptoms are more common than others. So this was the screening questionnaire, and then the control group, I had medical students as a control group, but basically your average person that did not have Lyme had 4 of these 280 symptoms, whereas the average patient who had Lyme had 82 of these symptoms. And the average person who has some other chronic illness had 22 of these symptoms. And I used 4 control groups. One was the National Comorbidity Replication Study that validated my baseline, showing, so when I broke it down into the different symptom clusters. One was attention span. So the left was the before infection, and then the confidence interval. Then to the right is what the percent of the people that had that symptom afterwards. At the top in each of these groups is the more prevalent symptom. So 84% of my Lyme patients had trouble sustaining attention span, whereas beforehand only 7% did, which is pretty much what you'd expect in a normal population with AD. Now, if you look at that, then it looks like an acquired pattern of ADD, but there is a difference because you see that with Lyme patients, they're often environmentally sensitive, hypersensitive to sound, light, touch, smell, but also they get this sensory flooding, sensory overload. You don't see that with attention deficit disorder. There's distractibility, but not the sensory flooding. So it's qualitatively different. Now, what I'm doing now is I'm breaking down, looking at symptom clusters. And among the cognitive, there's attention, memory, processing, and executive function. Those are the 4 areas. So the memory issues, particularly working memory, 78%. And remote memory is comparatively more intact. And retrieval, things like word retrieval or motor memory, where some people, they have to think out each step, where I say, put on your clothes, so they just can't do it. They have to think it out. That's a lower percent and can be much more severe. You also see a lot of dyslexia symptoms where this is processing, and that goes with the white matter that we were talking about yesterday, where there's lack of collateral circulation to the white matter. So there's slow processing, and it's almost like a Peanuts cartoon where when the adults are talking, it's wah, 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 wah. You know, it's hard for someone to digest when someone's incoming, but also difficulty with expressing, where you can see someone's, what do you call it? I'm trying to think of the right word, where they're groping around and very slow in expressing their thoughts. But then we can break it down into different processing subcategories, which you kind of think of as dyslexia type symptoms. Then there's executive functioning. Executive functioning is the ability to create and sustain goal-directed behavior. So you're looking at brain fog, trouble concentrating, prioritizing, multitasking, and time management. Now, some of these I didn't analyze, but a lot of people with Lyme disease lose track of time. And these were people that used to be good at it before. Imagery, this is something I want to comment on, and this is something that deserves attention. A lot of people have these intrusive, who have Lyme, have these intrusive images or intrusive thoughts or intrusive emotions. And they just come, and it's contrary, it's not something that they would choose to think. And it's, and sometimes hallucinations, but it's different than what I see with schizophrenia. They know they're hallucinations, unlike someone who's schizophrenic. And it just, it can be like a radio on in the background, and there can be an intrusive image or intrusive thought that can be quite disturbing. So this is an example of what a patient said of, you know, it's a horrific intrusive image, or they could be violent images or sexual images. And she says, it invades the privacy of my mind. So it's almost like a horror show where you click on a horror show on TV. And then we see other behavioral symptoms: low frustration tolerance, 80%, mood swings, anhedonia. Anhedonia can go a lot with suicidal risk when you don't have pleasure of life. Hyperarousal, depersonalization, where you feel like you're there, but you're not there. And then 78% looking at behavior things, decreased job productivity and decreased social functioning. That's very significant. So your functional abilities are compromised. And then a lot of other things, and homicidal down there at the bottom, but suicide, 28%. So a significant amount of people that get suicidal. In one of my, where I studied 50 homicidal Lyme patients, 49 out of the 50 were also suicidal. So it's a combination somehow when you see the homicidality that it goes with suicidality. So this was a study I did on suicide, and I estimated, and I think there's 2 basic ways. There's a physiological thing that makes someone suicidal on a biochemical basis, on a neurochemical basis, but also the frustration of dealing with disease. I estimate there's probably about 1,200 suicides from Lyme each year. I get a lot of these calls from people telling me their story about it. And it's now also, Brian Fallon did a study on suicide. He looked at the database in Denmark and found that it was significant. It was a very different kind of study he did, but it supported basically what I found. What I'm looking at now more is drug abuse and death from overdoses. And when people feel lost and they're not adequately treated for anxiety, insomnia, pain, then they do drug seeking, and then you see a fair amount of deaths from. So I think the #1 cause of death may be suicide, but I think there's a lot of deaths with these infections that are substance abuse. This is a case that I presented, and it was someone who was on my waiting list, and he was treated really quite a bit with, and they missed the diagnosis. Somebody said, well, that's probably not Lyme, don't treat it. And then somebody else gave 1 month of doxycycline, and then he relapsed when they stopped it. And then they said, well, you had a month, that should have been enough. Yeah, but my symptoms are worse. But then he declined. He was frustrated with the healthcare system, turned to substance abuse and found PCP. And that made sense with the NMDA site, and that gave him relief, but then he binged on it, withdrew from it, and then he killed his best friend, assaulted 2 family members, and then killed himself. And we did an autopsy study. So we found an increase of quinolinic acid in the brain. We also found, in spite of all the antibiotics, we found spirochetes in the heart and pancreas. Now, what you find is there's what's called serious mental illness. Serious mental illness are bipolar, schizophrenia, and autism. And if we look at those conditions, they affect brain, they have metabolic effects like with diabetes and cardiovascular effects. And he had all 3. So that can explain that these are multi-system illness. And a lot of people with bipolar and schizophrenia die from the metabolic or the cardiac rather than the brain disease. So we see the different psychiatric symptoms. We see depression is number 1, 79%. But we also see panic attacks, particularly if a panic attack goes more than a half hour. You think of it as being associated with Lyme, but is it Lyme or is it a co-infection with Bartonella? It's hard to tell. And social anxiety, OCD, particularly when there's an autoimmune component, PTSD and trauma and having PTSD are 2 different things. But PTSD is a distinct entity. The intrusive symptoms, like I was talking about, that's the hallmark of PTSD. And sometimes rapid cycling bipolar, particularly when they're infected when they're very young. Dr. Greenberg, who works with young children, she looked at her childhood onset bipolar cases, and a very large number of them had tick-borne diseases. So fatigue, 76% had fatigue, similar to those other 2 studies, but 76% also had non-restorative sleep. We can also see different sleep disorders. We can see eating disorders, sexual disorders. Some people are hyposexual, some people are hypersexual, just like with sleep. Some people don't sleep and they're tired and wired. Some people sleep too much. That's the brainstem, the vegetative symptoms. Temperature dysregulation issues we see, and 7 different kinds of headaches. And the most common one is a pressure sensation that someone describes. It could also be cervical radiculopathy, where it's from the neck and it shoots up. But it's, and these headaches often have multiple components. So you may have one type of headache and then it involves the second or a third. So it's like a symphony of pain in your head. Cranial nerves, all cranial nerves being affected. A lot of eye symptoms, I'm not going to go into the detail with it. For instance, light, there's an inability a lot of times for pupils to constrict, so there's light sensitivity. Also sensitivity to fluorescent light. People can't go into certain stores where there's a certain, like sodium vapor light with a certain flickering effect. And I find a lot of 8th nerve problems. I think that's particularly common. I think more so than 7th nerve. But when you do a thorough cranial nerve assessment, you find a lot of cranial nerve symptoms in these people. Even like having them stick out their tongue and it goes sideways. So seizures, partial seizures a lot, absent seizures. Sometimes they don't show on EEGs, so they say, well, it's psychogenic, but you give these people anticonvulsants and it stops the seizures. And every now and then gram-mal, but mostly it's partial. And then a lot of your neuropathy symptoms, the tingling, people feel a sense of vibration. You see a positive Romberg with a lot of people. I'm not going to go into all these, but it's some people with a sense their skin is wet. It's that, you know, there's always a new symptom that now I pay attention to. And then when I ask people, I find a lot of people have it. And like I say, I learn from my patients. And then you can see the Herxheimer reaction. The symptoms can kind of fluctuate. They can be cyclic with the reproduction of the organism. And then other studies, that was my study, but there were a lot of other studies looking at symptoms, and it was rather comparable. And these different studies looked at different symptoms. That I'm just doing the neuropsych. And the study that really had the most, for instance, was depression, which there was 11 other studies looking at depression and panic attacks, post-traumatic stress, etc. So, or suicidal studies, there were quite a few that looked at suicidality, and then some of the physical things. So treatment, how do you treat it when you have so many symptoms? So what I find, and I've treated thousands of patients, and how did I get involved with this? I was trained as a psychoanalyst, and most people in my era, that's how they were trained. And I specialized in treating treatment-resistant cases. And in treating treatment-resistant cases, this just coming up again and again. And we had a discussion this morning. When did I see my first Lyme patient? 1973, I think. But at the time, I didn't recognize it as Lyme. But I look back, I'm sure it was Lyme. And I've seen them, every psychiatrist sees Lyme throughout their entire career, but they don't always recognize it, almost like with the Yogi Berra quote. And so I think when I do these, and over the years, so I get these patients and it's like, well, who can I send them to? So when I treated treatment-resistant cases, it just kept coming up again and again and again. And I couldn't find anybody else to send them to. It was kind of like Dr. Green's experience, where then you have to research it and figure it out yourself, because how else are you going to do it? So I figured it out, and then I treated these people and wrote articles trying to get other people to learn about it and treat their fair share. But then I'd get all these phone calls, and I'm always trying to train other people with this, but there's just so many of these patients. So when I go through that assessment that I just did, and I didn't do the full assessment, I just did the neuropsych part, it takes a good 2 hours. And then at the end, I say, well, what's your worst symptom? If I can only help one symptom, what would you pick first, second, and third? Now realize that there's 3 ways to treat. Treat the infection, stabilize the immune system, or treat the symptoms. And you kind of do what hasn't been done before. So the person that's been on 10 years of antibiotics, you may say treat the symptoms. The person who's been on 50 psych meds and never have been on antibiotics, you might think of the antibiotic, right? Or you have to kind of use your judgment there. But when I go through this, and I've asked thousands of people, I could only treat one symptom. Okay, I've had people that have 200 symptoms, or the average person I said like has 82 symptoms. Am I going to give 82 drugs? No, that doesn't make sense. So I say, well, what's the linchpin? What do I treat first? And most often it's getting non-restorative sleep. So if I treat the sleep, that's something that often has a ripple effect that helps other things. Or the other thing would be, what emotional symptom you have that stresses you out? Is it drug abuse? Is it depression? Is it anxiety? Is it suicidality? Hallucinations? I treat that, and then I work my way down the list. And so it may be chronic pain, somatic symptoms. So that's the basic strategy to use. And so how do you do a controlled study with that? You just have to show improvement by using this basic strategy, I think. And what perpetuates it may be different than what triggered it. So chronic stress, non-restorative sleep, what symptom impedes recovery? How do these symptoms interact with each other? For instance, I may have a person who has intrusive symptoms that gives nightmares. So now they're afraid to go to sleep because of the intrusive symptoms. So then I'll give a med that would reduce the intrusive symptoms, and then they may do better. You have to kind of sort it out. So back to that schedule, you may be treating the infection that is most contributory, and that's a question in and of itself when there's these interactive co-infections. And think of the word polymorbidity. It's not comorbidity, where it's 2 infections, it's polymorbidity. The greater the polymorbidity, the greater likelihood it's a multi-system illness that could be triggered by something such an infection. So how do you treat the infection when it's a complex interactive infection? And what can you do for the immune system so the immune system is really more specific towards helping recovery? And how, when you're in stress mode, you're compromised, you're immunocompromised. How do you get out of stress mode that causes disease progression? And part is education, so the person knows what they're dealing with and can look at it logically, and educating the people that they're working with. A lot of Lyme patients need super low doses because they have low body temperature or for other reasons. So a lot of times the lowest dose can be too strong. So a lot of times they have to get the lowest dose of the med and start with a fraction of it. So this is a quote from Osler again. The young physician starts life with 20 drugs for each disease, and the older physician ends with 1 drug for 20 diseases. So I often figure out, well, gee, let me think. You have GI problems, so I could think of doxepin that helps stabilize irritable gut and nervous stomach, and it could help anxiety, could help delta sleep, and it could help anxiety. So maybe I'll try that, so I can get more bang for my buck and get the most effect with the least risk and the least complexity to treatment. So treatment can work. This is a case I studied, I published in 2007. This particular person, it showed a SPECT scan before and after treatment. Now they had 16 months of IV ceftriaxone treatment to improve their function. There really aren't many studies like this showing improvement post-treatment, but this is one example of it. So although this is a new concept and people don't like new concepts, they often fight it. But recognizing cryptic infections, I think, is the future of psychiatry. And I think it's the future of medicine, because I think that's a big part of what we have to understand. We can't just recognize these infections, but we have to look at that immune, the psychoimmunology, the pathophysiology, and how all that works, that second part. And then we have to look at the symptoms and how all those things interact with each other. And it leads to a lot of developmental impairments. It leads to learning disabilities, many mental illnesses. I think most mental illnesses probably have some role with infections of some sort at some point in the person's history. I think trauma also plays a role, but I think infections, I lean to that more and more. Many chronic medical illnesses, disability, suffering, death, suicide, and also the violence risk that we live in a world where all it takes is one very unstable person with brain injury and we're at risk. And how do we know that some people that are in control of that are mentally stable? So I think it's something that we really have a need to share and make other people understand. And I think the suicide, the violence, the disability, the birth defects, I think that's really a reason to wake up. We have to be aware of this, and we have to look at that risk-benefit consideration. And when someone says, well, give them 200 milligrams of doxycycline, that should be enough. But if they have a pimple in their nose, they get 6 months of doxycycline. And I think, my God, we have to educate the world to be more aware of the risk of undertreating these things can be catastrophic. So thanks for your attention, and any questions or comments?
Robert, do you have questions? No, everything is clear.
Everybody knows exactly what to do with these people now, okay? Right.
Okay, well, any question on mine or Bartonella?
I would just like to make a comment. And every time I see a patient with Lyme or COVID, I kind of write down, what did your GP see? What did the specialist say to you? And the term that patients use is kind of gaslighting, and I just keep on getting back to this, is that you end up getting put into the psychiatric basket because you've got neuroinflammation. And one of my favorites is a patient that ended up admitted in Galway, and the infectious disease doctor stood at the bottom of the bed and said, "You don't have Lyme, you never had Lyme, are you having trouble at home with your husband?" But these are the kind of comments that happen. And then every week I'm seeing patients with long COVID, and they're horribly traumatized because they have this misery condition. And then they've gone to see the GP 10 times, and the GP is frustrated. Now, some GPs are hugely supportive, but some are just frustrated when they don't know what to do. And patients start misbelieving that they have a medical condition. They said, maybe I am crazy. They start putting themselves in the crazy basket as well. And I just think that neuroinflammation is a trigger
Yes.
for many conditions, and not disagreeing that they need psychiatric support. But I have so many people that have been sent to psychiatrists because your problem's psychiatric. The psychiatrist says, your problem is not psychiatric, you've got an infectious disease. Go back to see the infectious disease doctor. So I just think that we keep on turfing people to somebody else because we can't figure it out. And I think we're stronger together.
Yeah, well, I think when I look at it, why are people referred to psychiatrists? I think there's three reasons. One is that someone says, I can't figure it out, so it's all in your head. But the other is that these people feel abandoned. They have something happen to them that they can't explain, so that's overwhelming. Their family can't understand it, and it says, just pull yourself up by your bootstrap. Their family doctor doesn't understand it. The CDC, NIH, they don't understand it. Nobody, the insurance companies understands it, but they don't want to let you know they understand it, okay? So everywhere as you go, because if you go and buy a disability policy and say you have Lyme, they won't sell it to you. But if you have Lyme and you want a disability claim, they say, oh no, it's the aches and pains of daily living. That's a quote from the IDSA guidelines. So it's then the person gets frustrated. So people come to psychiatrists because they feel flooded and overwhelmed with an invisible illness. And that's the second reason. But, you know, also the third reason is because of the nature of this, it really causes a lot of neuropsych symptoms. Now, you know, the one question here is, why are so many psychiatrists not aware? You know, I try educating them, and I have this thing, it's called Microbes and Mental Illness, and I've been doing it for 24 years now, and there's over 700 people in that. It's a discussion group to try to educate other psychiatrists. So we are expanding the ranks, but as soon as we get someone online who understands it, they get flooded and overwhelmed with patients, and they can't take any more patients because there's just so many patients like this. And I write journal articles. There's a lot of us that write journal articles. Like I said, there's hundreds of articles supporting this. And actually, this is in the guidelines of the American Psychiatric Association. The American Psychiatric Association is 36,000 members, and in the guidelines for the treatment of adults, or the assessment of adults, they recognize Lyme disease as something that should be considered in the evaluation of someone with psychiatric symptoms. Now, I think the people that do better are maybe family doctors, psychiatrists, nurse practitioners, people that are closer to the patients. I think the people that often have the greatest trouble are some arrogant super specialists that think they know everything. Some internal medicine super specialists. I can't say that about all of them, but I think there's you can kind of tell where someone is just algorithm oriented and they're black and white, and they don't stop and think when something doesn't fit into the algorithm. So there are people that understand this, and it is expanding. And like I said, when I was here in Ireland last time, I was getting nowhere as trying to get awareness, but look at how far you've come now compared to where I was 13 years ago. So we are making headway, but it's these things happen slowly, and we need to speed it up. And there's questions about where to find doctors. I think if you can just I can't treat everybody, and my staff at the front desk gets traumatized with all these phone calls, these desperate phone calls. If somebody can get a doctor or psychiatrist that has an open mind and is curious, then get me their email and I'll put them on the microbes and mental illness list. And that's the article that I'm trying to finalize, where it expands it, and that's what I was quoting in the beginning of this presentation. I hope that would expand awareness, and I think some of the articles have done have expanded awareness, but we need much more of it.
Okay.
So I think
I agree with you. And in my experience, I saw that a good psychiatrist was a physician with a good neurologic education, internal medicine indication, family practice. We see so many psychiatrists that only practice psychoanalysis because they have personal problems, but they are not real physicians. And just the last question about heavy metals, and then we stop.
Well, I think if you look at disease contributors, heavy metals is a part. So it isn't like if you look at what are the contributors that throw off your immune system, I think number one is infection, number two could be allergies, and then toxins is probably next. And then there's a long list of things, but I think that's on the list. There's multiple cofactors that contribute. So it's the balancing act. And if you have too many contributors and not enough disease deterrents, then that triggers disease progression. That's a complex model that you have to look at. I think that incorporates all these contributors, like I showed in those diagrams.
Okay, thank you.